good afternoon, everybody. We have our instruction course on the macular and submacular surgery updates. And I would like to call, I'm Dr. Abhijit Chattopadhyay from Priyambada Pilla Arvind Eye Hospital. I'd like to call my co-instructors on the stage, Dr. V.S. Saravanan, Priyambada, this Arvind Eye Hospital, Coimbatore, consultant, Dr. George Manayat, consultant, Arvind Eye Hospital, Coimbatore, Dr. Naresh Babu, Arvind Eye Hospital, Madurai consultant, and Dr. Subhankar Sripal. But before that, we have one keynote address by Dr. Alok Tegriwal that is on treatment of diabetic macular edema in Indian settings, treat and extend regime. Dr. Alok Tegriwal is MS DNB and FRC Opt, and he's posted in Lincolnshire Hospital NHS Trust for last 27 years. So I'll call Dr. Alok Tegriwal, sir. Excuse me, this. From here, sir. They already got it. Okay. Use this one.
Yeah, sure. Thank you, Dr. Abhijit. I have a short talk on treatment of diabetic macular edema in an Indian setting. And what I'm going to propose is treat and extend is the way forward. So as you probably know, these are the landmark studies in diabetic macular edema, the drcr.net, Right Rise for Lucentis, Vivid Vista for Eylea, and Retain for Lucentis. Now, I would commend you to all go through the drcr.net protocols. That's one of the best ophthalmic studies in recent history. And that's what most of us in the world, we follow their protocol. Now, one need not need to go through all the study. All the studies show that on an average, the patients gain about 10 to 15 letters of vision. But in the study protocol, the patients are followed monthly. So some of them in these middle studies, they have a monthly injection, whereas in the drcr and Retain, they have a PRN injection. Now that is impractical even in our Western setting. Even in the UK, we don't follow that protocol. We don't give them monthly injection or monthly follow-up. So what do we actually do? So just to highlight that the research protocol is important to show us what is the way forward, what is the way to treat. But then we adapt it to our practice to see what we can actually offer to our patients. So the problem in the real life situation is that monthly visit for the patient is impractical. Now, in our group of patients, some patients will not respond. So there's no point in giving them monthly injection if they're not responding. And some patients will respond with 3 or 4 injections, and there's dry macula. Again, there's no point in continuing to give them a monthly injection. So, but in the trial protocol, the protocol is decided before the patients are enrolled in the trial, and they will carry on for 12 months or 24 months, whatever the protocol is. So that again is impractical in the real life situation. So I'm based in Lincolnshire, and I'm the retinal lead there. So this is the protocol that we have developed, and that's what I will go through. And the same protocol can be followed by all of you. It's quite straightforward and very effective. So the patient comes to my clinic, and they have a diabetic macular edema. The first thing to ask and to find out whether the fovea is involved or not. So if the fovea is not involved, then you do a grid laser and then keep on following them. And you repeat the laser at every 3 months. So generally, if you have done the grid laser properly, it need not to be done less than 3 months apart. If the fovea is involved, then the first line of treatment there is to give 4 monthly injections. We have in the NHS, there is no cost to the patient, so I choose between Lucentis and Eylea. If the patient's vision is better than 618, then I give them Lucentis. If it's better than, worse than 618, then I give them Eylea. And after 4 injections, we see how they're doing. If they are dry, then I just watch them. So after 4 injections, I would again classify them into 3 groups. So if they are dry, so that I would say that they are success, and then we watch without injection. If they're partial responder, so that they are better, but they're not completely dry, then I keep on giving them injections until they are dry. And the non-responder where there is no improvement at all after 4 injections, so there we look for other causes and we think of switching. So let's take up the group one by one. So the first group where after 4 injections the fovea is dry, then I don't inject them anymore, and put them into monitor and extend. So there is we're extending the follow-up. Extend here is extending the follow-up without injecting. So that's monitor and extend. So let's say I will book them to see my 4 weeks. Then if they're still dry, then 8 weeks, 12 weeks, 16 weeks, and so forth. So if the patient is dry at 16 weeks, that means the last injection was something like a year and a half ago. So these patients have done very well. But there's only a small group of patients in this group. What happens is that these patients who are initially dry, at some stage they will start to leak again. And at that point, I will put them into treat and extend. So I'll go through the treat and extend protocol here with you. So let's say these patients after 4 injections were dry, and after, let's say, another 4 months, they start to leak. So now they enter into treat and extend regime. And this is the regime. You give them monthly injection until they're dry again. And then you increase the interval by 4 weeks or by a month. So let's say after 3 injections, the fovea is dry. The next injection will be at 2 months. And even if the fovea is dry, you give them the next injection, and then follow them after 3 months. And if they're dry, then you give them another injection at 3 months. And so on, you increase the interval to 4 months. And after 4 months, you keep at 4 months for 3 cycles. And if they are still dry, then you enter them into monitor and extend. So the idea is that these patients should not have macular edema. So we give them injection before the macular edema recurs, because commonsensical approach says that whenever the macular edema recurs, there is some changes to the retina. We may not be able to record it either functionally or anatomically, but the macular edema always leads to some changes. So this treat and extend approach reduces the number of visits as well as reduces the damage to the retina. Now the second group where the patients are partial responder, so they have responded, but they are not completely dry. So you keep on injecting them every month until they are dry. So they will take two paths. Either they become dry. In that case, we will watch them and wait for recurrence. And if they recur, then we put them into treat and extend. Or the majority of the patient is that they improved partially, and they will stay there. So they will neither regress nor improve, even with monthly injection. So they will be the persistent edema. So this group with partial responded who have persistent edema even on monthly injection, then you look for other causes. So in my practice, I don't do a fluorescein angiogram when the patients first come to me. I will do this regime, laser or injection. And only when they're not responding, then I will do a fluorescein at that stage. So the 2 main causes for non-responder or partial responder is ischemia. So you can have foveal ischemia or peripheral ischemia. So if you find foveal ischemia, then you do laser at this stage. Remember, these patients had foveal edema. We started with the injection. We haven't given the laser yet. So I will give the laser at this stage. And if you find peripheral ischemia, then we do a PRP laser in the periphery. And of course, you look for vitreomacular traction. And if you find the vitreomacular traction, then however many injections we give, they will not respond. So they need a vitrectomy surgery. Now, you have looked for ischemia, you looked for traction, and given the grid laser, even then they haven't responded, then you switch. So by switching, most of the patients, we have already given anti-VEGF. So normally I would switch to the steroid. So we have access to Ozurdex, which is dexamethasone, similar to triamcinolone. So I think in Indian setting, you can try triamcinolone in these patients. Now, in the group which initially, there were 3 groups. So the third group is where they haven't responded at all. Now, again, you look for the secondary causes. And if you don't find any cause, then this group is very difficult to treat. You can try a switch, or you can try combination therapy, you can try vitrectomy or metabolic control, but they are the difficult ones to control. So in summary, I would say that I treat all sorts of medical retina patients, but diabetic patients are the most satisfying to treat. They respond very well. The problem here is the patient motivation. They are young patients, and they don't see any problem with their eyes mostly, and they don't understand why I want to bombard them with laser, bombard with them with injection when they can see properly. So patient motivation is the bottleneck here. I won't go through into that, but that's the flow chart that we follow. You can write to me. I can send it to you by email. And thank you very much for having me.
Thank you, sir, for this talk on diabetic macular edema management. Any questions from the audience for this? Okay, I think we'll proceed with the instruction course on updates on macular and submacular surgery. The first speaker is Dr. Abhijit Chattopadhyay.
I'm just telling the updates on the next slide, please. So these are the topics we are going to cover. These are the faculty members. So first, we are going to call Dr. Shubhankar Paul, and he is going to give us some insights into Vitreo-Retinal Interface and the epiretinal membrane peeling. Everybody is having 10 minutes each, and then we will have discussion also. Let us start.
Good evening. I'll be presenting Vitreo-Retinal Interface and epiretinal membrane peeling. I thank Dr. Abhijit for giving me an opportunity to present in this IC. The topic is very vast and difficult to manage in 10 minutes, but I'll be highlighting only salient features. So I have no financial interest. Vitreo-Retinal Interface is made up of posterior vitreous cortex, internal limiting lamina of retina, and intervening extracellular matrix. The posterior vitreous cortex is densely packed with collagen fibrils and the special cell called hyalurocyte, which are responsible for ongoing synthesis of collagens, different glycoproteins, and it is also has a role in macular pucker when there is anomalous PVD and the vitreous crisis leaves the cells on the retinal surface. The internal limiting membrane has got specialized collagen which are responsible for vitreoretinal adhesions, and also it prevents cell migration from the retina to the vitreous. The extracellular matrix made up of fibronectin, laminin, and other glycoproteins which acts as a glue between vitreous cortex and the internal limiting lamina. So there are topographic variations. The adhesions are strongest at the vitreous base due to high density of collagen fibrils. Because of the anatomical variation in the peripheral fundus, there may be associated with retinal breaks. The internal limiting membrane is thin, sometimes absent over the major vessels and also over the macula, where the glial cells extends onto the inner retinal surface. So we have two entities in the vitreomacular traction. One is the vitreomacular adhesions, where the posterior hyaloid is attached to the macula, but there is no deformity of the foveal contour, or there is no intraretinal changes. But if it is associated with the distortion of foveal contour or intraretinal changes, then it's called vitreoretinal traction. It can be focal if the width of the attachment is less than 1500 microns, or diffuse if the width is more than 1500. The epiretinal membrane is basically known as a cellophane maculopathy, or it is a cellular proliferation on the inner retinal surface present in 7 to 11% of the population, usually seen in the older age group, and it's bilateral only in 19 to 31%. Causes are mostly idiopathic, or it can be secondary to different retinal vascular disease, inflammation, detachment surgery, tumor or retinal dystrophy, or maybe following intraocular surgery, laser retinopexy. So GAS has classified different grades of ERM. Grade 0, which has got mild abnormality of the macular reflex, usually patients are asymptomatic and it's an incidental finding, maybe missed sometime. The grade 1 has got a minimal vascular tortuosity. Patient can have metamorphopsia or minimal blurring of vision. The eccentric type of grade 1 will not involve the center of the fovea, but in grade 2 there will be a opaque membrane underlying the vascular tortuosity. This may be associated with coronal spots or intraretinal hemorrhage. Sometimes the ERM is attached to the posterior hyaloid, and when the normal PVD occurs, it may get avulsed into the vitreous cavity. Sometimes it may be associated with a pseudo hole. So pathogenesis basically is a reactive gliosis secondary to various inflammation, ocular trauma, different growth factors and cytokines are expressed, which activates the Muller cells, causes migration and cellular proliferation. So investigation of choice, basically OCT will give the morphology about the Vitreo-Retinal Interface, which is surgically important, the height of the central macular thickness, the associated intraretinal changes, status of ISOS, which are prediction for the visual acuity. The FFA usually stains the ERM, and also secondary causes are ruled out by the FFA, which is required for the prognostic factor. Treatment usually surgery. Indication for surgery, if there is a patient complains of decreased vision less than 20/60, or a patient doesn't realize but there is a documented visual loss without excluding other causes, vision may be good but there is metamorphopsia, presence of diplopia or any occupational reason. Surgeries are usually Barcelona vitrectomy. The extent of vitreous removal depends on the surgeon, and PVD induction is done if it is absent, and triamcinolone assisted vitrectomy is usually preferred. So most important part of ERM peeling is the edge of the ERM. If there is a clearly visible edge, then it can be pulled with the, it can be engaged with the forceps and peeled successfully. But if there is no edge, then surgical pick or a bent tip MVR blade or diamond dusted scraper can be used to create an edge. The elevated edge on the retinal surface is then subsequently peeled with the forceps. The difficult situation when there is no definite edge or the extent of the ERM is not known, or if it is a densely adherent ERM, sometimes the posterior, it is adherent to the posterior hyaloid, and when you induce the PVD, it can cause retinal tear, or at the time of peeling itself, it can cause retinal tear. So usually we avoid the most adherent part, we peel the other areas, and lastly we peel the adherent area. The uses of roll of dye comes when there is extent of ERM is not known. The trypan blue is used as a positive stain, which stains the ERM and helps in peeling. The others like brilliant blue or ICG stains the underlying ILM, and it acts as a negative stain. But it should be used, ICG should be used cautiously because of RP toxicity. The role of ILM peeling, basically the ILM peeling removes the scaffold for the glial tissue to reproliferate, and thus it prevents recurrence. That way it can help in final visual outcome, but really if there is any role or not, it's still controversial. The complications are usually intraoperative petechial hemorrhage, which are self-resolving, peripheral retinal breaks, more common in 20 gauge vitrectomy, and nowadays it's less common because of 23, 25 gauge than the lens touch. Postoperatively, most common is cataract progression, then there can be retinal detachment, recurrence is less than 20%, and the macular hole formation 2.6%, especially at the edge of peeled ILM. The prognostic factors, usually the pre-op good visual acuity will have a ultimate final outcome of the vision will be more. The longer duration was the prognosis. If there is associated other like increased CMT, CME, pseudo-hole, then there is a worse prognosis. Centrally located dense ERM will have worse prognosis. If there is already disruption of ISOS junction or pre-existing macular pathology, will have a worse prognosis. So I'll be showing some videos of different. The first case is the ERM following a cryopexian barrage laser. So the edge of the ERM was elevated using a Finis loop, followed by pulling the ERM with the forceps. The brilliant blue was used to stain the ILM, and subsequent peeling of the ILM was done. The 1 month post-op visual acuity improved from 624 612. The second case is high-risk PDR case, status post multiple times laser anti-VEGF, and there was difficult to delineate the ERM, so ILM was stained and the ERM and ILM was tried to peel together. There was not much of improvement. The third case, idiopathic ERM, the hypertensive patient, again here extent of the ERM was not known, so ILM was stained the beginning itself. And the ERM was removed. The post-operatively there was a extrafoveal macular hole in this case. This case was a post-scleral buccal ERM with the posterior pole SRF. It was very difficult to peel the ILM and the ERM as the retina was detached there. So PFCL was used to flatten the retina and the subsequent peeling was done under PFCL. This case, while during the induction of PVD, the ILM got lifted up, and once the ERM got lifted up, once the ILM was stained, the ERM could be seen clearly, and subsequently the ILM was peeled. Thank you. Thank you, Dr. Abhijit, for the videos also.
There was like, can you just summarize on what will be the indications in your practice on when you will advise ERM peeling? Because ERM is a very common finding in most of the elderly people. And like,
so if a patient comes with the decrease in vision and clinically we see a dense opaque membrane there, then it's an indication. Suppose patient doesn't know about the decrease in visual loss, maybe his other eye is in good condition, but he is with us in follow-up, so we document and see that there is a loss of vision from the last visit to this visit, and there is no other causes like cataract. So in that case also we should, this is an indication for surgery. Again, vision may be good, but there is a micropsia or metamorphopsia. In that case also the surgeries are indicated. Sometimes patient can present with diplopia, or that time also we have to do the surgery.
So when would you prefer to do ILM peel with the ERM peeling?
It's removal of the ERM. In that case, we can stain the ILM and subsequently we peel the ILM with the ERM.
Next, Dr. Abhijit Chattopadhyay, macular hole surgery in difficult situations.
So good afternoon, everybody. We'll be trying to be short, no financial interest involved. So the first described by Knapp in 1869, and modern concept of the macular hole and classification given by gas. And prevalence varies from 3.3% in Baltimore study to 1.7%, and in bilateral cases up to 11.1% we can find. And first successfully operated by Kelly and Wendell and reported in 1991. So there are a few dyes we use for macular hole surgeries like triamcinolone, indocyanine green, tyrant blue, and brilliant blue. And there are some adjuvants also like autologous serum, tissue adhesives, transforming growth factor beta 2 and thrombin. And instruments, there are lots of instruments nowadays we use like ILM forceps, then diamond dusted scraper, then Sewell loops, that is Fennis loop, and PIC, and even PFCL also in some cases that we will see. So the case one, the difficulty is like this child of 8 years old and post-retinal detachment surgery, large size of the hole and the retina was unstable. Here we can see there is a giant retinal tear operated with silicone oil, and after that we got a full thickness macular hole. And we stained it with brilliant blue dye, and we peeled the epithelial membrane, and then we started to peel the ILM. Due to the large size, there is already some SRF in the posterior pole, and you can see that it is not enough stable. So, and this ERMs are attached with the arcade vessels also. So, here after first we peeled the epithelial membrane, and then you can see we put the PFCL because the ILM is not completely peeled off, which stabilizes the retina, and then we peeled up with the end grasping forceps, then which you can see you can do it completely. And then we did the fluid exchange, getting the last few drops from the macular hole itself. And injected C3 with gas. And we can see this is a 2 weeks post-operative nicely closed macular hole. And the case 2 is a diabetic patient with old branch retinal vein obstruction with epithelial membrane. And there is laser scars near fovea causing adhesion of epithelial membrane and ILM. And here we can see it. The PVD is not complete also. And we did a 27 gauge vitrectomy. And we induced the posterior vitreous detachment with the tricot. And then we used that loop because first we tried with the ILM forceps, and we saw that there are plenty of epithelial membrane already which stained with the triamcinolone particles. And then we peeled from all around, and we used it as a reverse flap technique and peeled it up from all sides. And few of the areas are not coming with the loop, so we used the end grasping forceps also. And we trimmed it with the cutter with the low vacuum and high cut rate. And this is a nice technique. You don't have to do anything, just trim it and do fluid exchange and put the gas tamponade. We usually tell the patient to keep the head down for 3 days as much as possible, because when we fill it up with perfluoropropan, you don't have to be that much strict with the head down position. And never ever go to the macular hole in this type of cases, because the flap will be lost otherwise. You can see nicely closed hole. And this is a high myopia case with the staphyloma, and there is a vitreous schisis also and the retinal schisis, which we can see here. because the long axial lens itself causes problem. And then we stained with the brilliant blue dye. And when we are peeling it up, we realized that it was the posterior vitreous in fact, and it is not the ILM. So first we peeled it, see it is below the PFCL in fact. First we peeled the posterior vitreous, and after that we were able to reach to the ILM, and then we peeled it. And this is a traumatic macular hole with extensive scarring of retina and long duration of 2 years. And as we will be able to see, this is the situation. And you can see the papillomacular bundle area totally scarred with that full thickness hole. And here we could not get it up anything with the engrasping forceps. So we used the loop with very good effect. And it is literally only the 50% of the area we can peel the ILM, the other area it is out of question. And here also in this type of case even, it is really worthwhile to try. In fact, seeing that you may not try that, okay, it is gone, but as we saw astonishingly, it gave good result. And only this half you can do anything, but the other half is gone totally. And definitely we trim it. We don't try to keep the ILM calculating how many percentages you are going to keep. See, nothing is coming out from that scarred area because it is totally adherent. So this part only we can harvest. And we did a fluid exchange and put gas stamp on it. And after that you will be able to see the result. See, the macular hole is closed, and you can see the OCT also. Yeah. So this part is this is the V separate closer, but it is closed, and the vision improved also by 2 lines only. That is, I thought that is enough for this case. Thanks.
Can you just summarize on what are, like, when you first you talked about mobile retina, where the retina is mobile.
Yeah.
So what are the tips like in those cases?
Yeah, even the mobile retina means if it is like post RD, when we are taking out the oil, then also we are afraid that it may give rise to full detachment. So PFCL we have to use liberally. That is one of the tips. And then
in the first case you showed a large macular hole with elevated edges. So how to maximize outcomes in those?
Nowadays, in fact, we use the reverse flap technique much more in those cases. But before we used extensive peeling of the ILM. It is about more than 2 dix diameter, maybe from arcade to arcade, and sometimes, and most of the times under the PFCL. So it gives good result.
But actually, more than this, all these flaps, everything. On the table, if you wait patiently and drain every single drop of the fluid, maybe wait for 10 minutes also. If you dry the macula well, I think most of the time the hole closes.
Yeah,
I think
that is true.
drying is more important than.
Also, any tips for reaching the macula in high myopes?
Yeah, we got few special forceps from the instrument people, and particularly for because all our forceps is usually for 28 millimeter long. So eyes with 32 millimeter is really problem. So we got steel forceps and a titanium forceps built specifically for those things.
I think dark has a longer.
Yeah, and sometimes we take out the this thing also, the trocar, and directly we put it. So that way we can cover at least 2 millimeter more distance.
And this is one of the indications of doing a 20 gauge.
Yeah, that is fantastic.
One more point, like in cases with both high myopia as well as in very elderly people where the choroid is atrophic and the choriocapital is not that least healthy, the loss of contrast is a big issue.
That is
so what will be the best viewing system, or how do you maximize visualization of these eyes in these eyes?
Those times the lens, what you call the non-contact lens, the macular lenses are very much helpful. Then we have to stain maybe under PFCL also sometimes, because we don't know how much, and sometimes it is due to the retinal cases, some dyes go inside also in those cases. So to minimize that, I think the PFCL is a very good weapon. And
Also, I think restaining during the
yeah,
procedure.
2-3 times you may
Multiple
have to do.
times restaining also helps in some areas
But
which are not
previously we used to
stained.
stain with ICG. I think ICG was much better staining at that time.
Also regarding the forceps, like George uses the engrasping and you
Yeah.
prefer the ILM. Like how do you go about choosing forceps? Which like you have any like for this eyes I'll use this forceps. Or how do you go about choosing your forceps?
Forceps, I think that depends on the surgeon's preference also a lot of time. Whatever you do, the aim is this last, feeling the limb comfortably. Thank you.
So next we have Dr. George Manayath who will be talking to us on management of failed macular surgery. Normally the success of macular surgery is quite good, and but we do encounter cases where we have failed and sometimes it's a irritating thorn on the flesh. So we'll just see how he goes about treating these eyes.
So we have seen some difficult macular hole surgery. So when it fails, management of failed macular hole surgery is my topic. So before defining failure, let's look at success. Success is when we have a type 1 closure, where is a continuity after the closure. If you have a continuity of the ellipsoid zone of the photoreceptor, that is type 1 closure. Either in type 2 closure, you can have either a V type or a U type closure. In both cases, there is a discontinuity of the ellipsoid zone of the photoreceptors on SDOCT. So there is another type of closure. You see, this is not a failed macular hole. Here there is an outer lamellar defect. This is not a fail. These kind of cases takes longer time for the reorganization of the outer retinal layers. So this is not a failed. So now what is failed macular hole surgery? It is assume that in all these cases there has been an adequate ILM peeling and there is an adequate gas tamponade of at least 1 to 2 weeks, a good tamponade and prone positioning. So usually the ones which fail are the large ones with more than 800 microns size, or chronic holes with subretinal precipitates or RP degeneration, large myopic macular holes with foveal schisis like this, or large traumatic macular holes. So the usual surgical techniques that we use for prophylaxis of this miserable condition, it is better advised that these cases undergo large, the high risk holes undergo inverted flap technique. And the simplest of the surgical procedure is repeat fluid gas exchange in an early failure. When the hole fails within short period like 2 weeks of surgery, you have to think that either an inadequate positioning or inadequate tamponade has happened. And the other two procedures which are being used and which we will be discussing with videos are free ILM flap technique and lens capsular flap transplantation. The rarely described techniques for a failed macular hole is arcuate retinotomies, radial incisions, autologous free retinal flap from the temporal periphery, and so on. So the inverted flap technique, first described by Navraki. So he said we peel this ILM in a radial fashion towards the macular hole, bring it till the edge of the hole, from all the sides, bring it till the edge of the hole, and then trim these flaps and fold it into the macular hole area. So how it helps is because these ILM flaps have neurotrophic factors which helps in the migration, rather than only scaffolding, it helps in the migration of Mueller cells, which again secretes neurotrophic factors, and that helps in the reorganization and survival of the photoreceptor cells, causing a macular hole. So now once all these flaps are trimmed, it is fluid air exchange is done, and generally with a soft tip cannula, the flap which is trimmed is placed into the whole area. So this is basically done to prevent a failed macular hole surgery when you have a large hole like 800 micron. So the simplest surgery available for a failed surgery in the early period, that is like 2 weeks from the surgery, you see that hole you have a small bubble up and you see the hole is still open. And if you have this kind of a configuration where you have elevated edges with a cuff of retina with subretinal fluid rather than a flat punched out hole, you have a high chance of closure with just a repeat fluid gas exchange with a long-acting gas tamponade like C3F8, because here the causes of failure is different. It's just inadequate positioning or inadequate duration of tamponade. So when these are few cases wherein you can see these cuff of retina standing up with a little bit of subretinal fluid, which closes with just a simple fluid gas exchange. So the commonest performed procedure now for failed macular hole is ILM free flap, wherein a small piece of the ILM is taken from the edge of the already peeled area and put it into the macular hole. So various people have tried different techniques of doing this. However, we feel that rather taking from the edge of the already peeled area and putting wherein the flap can float away. So better done under PFCL. Under the PFCL, you can inject BBG dye, and that stains this ILM. The edge of the ILM area can be seen quite clearly. And then according to the hole size, just pick up a small flap of ILM from the already nicely seen area like this and shift it under the PFCL. Just place it on the macular hole. As you can see, now that flap is lifted and put it on the macular hole. So, and just use a soft tip or instrument to slightly nudge it into the macular hole area. And after this, a careful fluid air exchange at the disc with low air pressure has to be done so that this doesn't get dislodged during the FAE procedure. So even people have tried, because of the dislodgement of the flap, people have tried attached ILM transplantation, wherein the ILM, a hinged flap is raised and the tip of this flap is put into the tucked into the macular hole area. As you can see, under the air, you can see the flap tip is under the macular hole and this helps in closure of the macular hole. Another technique that we do, and it is being advocated now, is a lens capsule transplantation. For example, in a pseudophakic patient like this, the posterior capsule is just dyed, use dye, trypan blue or ICG dye to stain the posterior capsule, and with the microforceps, pick a small piece of the posterior capsule, which is dye is applied, and put it on the macular hole, and gradually with the forceps nudge it into the manipulate it into the macular hole area. If not tucked properly also, it stays there, and careful fluid air exchange is done so that this doesn't get dislodged. So post-operatively, if you look at it, these flaps are seen up to 2 weeks or 1 month following the surgery until the macular hole closes. So this main mechanism, how this helps is by acting as a scaffold, preventing the fluid from entering into the macular hole, and also helps in the migration and of the Mueller cells. And as you can see here, 1 month later, the hole has closed, and the scaffold of the tiny remnants of the capsular flap is also seen. So even if it's a case which you do a combined cataract surgery along with failed macular hole surgery, you can do a cataract. Trypan blue stained anterior capsule is preserved during the cataract surgery. It is kept moist during the cataract surgery, and after that it is hand fashioned into a 1 to 2 millimeter size according to the size of the macular hole. And then after a fluid air exchange, this capsular flap is with a drop of visco applied on it, can be just placed on the macular hole. So this again acts as a scaffold over this macular hole and results in closure of the macular hole. This is how it is being placed on the macula with a drop of viscoelastic, which helps to retain this capsule in position. So this failed surgery with this capsule as a scaffold, it closed after in the postoperative period. So the other techniques described, like autologous retinal free flap from the temporal periphery under the perfluorocarbon liquid, after the cautery, a small piece of retina from the periphery is removed, and under the PFCL, it is taken and placed over the macular hole. So it was basically done for failed myopic macular holes, and you can see the flap in the initial period. Later phases, it is taken up, and you can the retinal flap is taken up, and you can see the whole closed macular hole. Steve Charles described arcuate C-shaped temporal retinotomy, which is temporal to the macula, and this fashion of creation, it doesn't cut the nerve fiber layer, because that is according to the configuration of the nerve fiber layer, and gradually, slowly, the retinal bridge here is nudged nasally, so that there is a shortening, horizontal shortening of the macular hole, and it closes. That is the mechanism. This is one of the patient of failed macular hole following temporal arcuate retinotomy. So the radial incisions also have been described for large failed traumatic macular holes, wherein sparing the papillomacular bundle, 1 disc diameter radial relaxing incisions have been made, followed by fluid air exchange and long-acting gas tamponade. So the adjuvants that are used for all these procedures, which we flap surgeries and transplant surgeries, are mainly viscoelastics, autologous platelet concentrate, or whole blood. So this is mainly used so that after the ILM flap or retinal flap or the posterior capsular, posterior capsule of the lens is being placed there, these adjuvants are used so that it doesn't get dislocated from the area of macular hole during the fluid air exchange and the postoperative period. So to conclude, the above described techniques are useful, especially for large and refractory macular holes which have failed the standard procedure of ILM peeling and gas tamponade. These novel techniques are advancement in surgical techniques with better anatomical outcomes, but the long-term functional outcomes are yet to be analyzed. Thank you, and I thank Dr. Karan and Dr. Saravanan for the help in this presentation. Thank you.
Dr. Jaj, literally, I think macular hole is becoming like a garbage bin. You are filling it to every possible thing.
So, yeah.
No, what is your preferred technique?
No, ILM free flap is the easiest thing under PFCL. But then now, because of this techniques without PFCL when being used, it's so flimsy. The free ILM flap, if you're not using the PFCL, the techniques which we showed, it will just float around. By the time you take and place on the macula and under the water, it just floats around. So that is why people have the PC and the anterior capsule is much thicker, and it doesn't float around so much. That's why the use of these flaps actually.
No, usually we have to tuck at least 2.5 times the size of the hole.
Yeah.
So that is possible when you are doing an inverted flap. So, but so we have to be very cautious when we are lifting the free flap also, so that it is at least 1.5 times the size of, or it is more than that.
No, it is. Suppose the hole size is 1 millimeter, at least 2 millimeter, 1.5 to 2 millimeter size, as you rightly mentioned, has to a little larger flap, whether it be posterior capsule or ILM, a little larger one, and gently place on it and nudged it in. Some people tuck it into the, but then it's more traumatic than thing. So now even one of the surgeons was showing use of viscoelastic, like that really helps, retains the thing after the FA. So probably viscoelastic is a good, and I think you are using blood, isn't it? Like
no, plasma.
Plasma.
PRP. No, but the thing is, I differ with this visc because I personally feel like in pseudophakic eyes, if you analyze, the closure rate is much better with the pseudophakic eyes or phakic eyes. When you compare them with combined cases, I think the macular hole closure is relatively less, probably because of the seepage of the visc from the viscoelastic from the anterior chamber coming and keeping the whole pattern. So I don't know, I usually don't buy the idea of putting the visc into the macular hole, because it might prevent the, or maybe keep the hole open.
Visco.
Visc.
Mainly here the point of using visco is to sort of avoid slippage of the flaps usually.
Yeah, but that will be retained for at least 48 hours.
ask one question? I was just wondering that since we are moving that anything you put, like you put inside the hole, why don't we, have you tried not peeling the ILM and just putting a sort of in a fresh hole, I'm not saying a recurrent hole, just put a posterior capsule, a flap, a little bit part of it. Means I'm just discussing that aloud, you know, as a thought process.
You mean in a treatment
naive patient also?
Yeah, probably.
I'm just giving a thought, you know, what is your opinion on that, you know?
No,
because
it will act as a scaffold because the fresh hole will close much more easily, you know. So if that is working in these chronic holes, it should work much more easier in a naive hole is what I'm just thinking. Just thought
maybe
arrived.
Because we have a standard procedure which gives around 90% success. I think everybody for a small regular hole, everybody just, I think it's a
no, but I feel, you know,
good out of the box
peeling,
thought.
Yeah. ILM peeling, I think finally over the time we'll find that there is definitely some trauma which is happening at the microscopic level which we don't realize today. You know, we'll have certain, you know, advancements in imaging where we'll realize that the ILM peeling is definitely traumatic in certain ways to the retina. Yeah, maybe.
But only issue is before doing that you have to get the IRB approval because it's not the standard.
Yes, that I agree with you. I'm just
but these are all procedures which we have seen now. It's been studied and we have publications on this capsule. And
I agree with you that.
Thing is, already there are published data on the bad effects of ILM peeling. The
yes, that's true.
dissociated nerve fiber layer defects, loss of ganglion cells.
That's what I was saying. And especially if you're using a diamond dusted scraper, then there's even RPE damage which is happening, you know.
These are better picked up the blue filter photographs. The defects are much better picked up.
Yeah, the multimodal imaging of HRA.
Definitely.
Yes. Thanks.
Thank you.
So thank you, Dr. George. Now we'll call Dr. Naresh Babu for management of submacular hemorrhage.
Thank you, Abhijit, for the opportunity. Actually, from so far we have been talking over the macula. Just for a change, I think we'll go under the macula. So what happens in this? And these are my financial disclosure. Okay, so submacular hemorrhage, just for me to remember what it is, submacular hemorrhage. It's basically the presence of blood in the potential space that is between the retinal pigment epithelium and the RPE actually. So we come across this quite often nowadays, especially in case of PCV. In fact, in PCV we have got a lot of cases with the breakthrough vitreous hemorrhage and the subretinal hemorrhage. So in such cases, when we go for vitrectomy, we can have surprises with a lot of subretinal bleed in this. The other cases includes AMD, and when we do the surgery, we ourselves cause a lot of subretinal bleed, especially when you're draining in case of scleral buckling. Usually now we go for the blind needle drainage procedure. There is always a chance when you drain somewhere at 14711, 15711 where the vortex is there is always a possibility of subretinal bleed. If it is very minimal and if the break is superior, inject the gas, it's fine. Otherwise, if it's massive, then we'll have to convert that into vitrectomy, or later on also we'll have to go for vitrectomy to evacuate the blood. And especially now we are doing a lot of valve for glaucoma. And there is always a chance of perforation during that. And of course, the other indications other causes and indications where we have subretinal bleed is trauma and RAM. In fact, RAM will have blood in all the three layers. And these are the main reasons why we have to remove the blood, because the presence of iron and hemosiderin and fibrin in the blood can be toxic. It says that it is as early as 24 hours you can have the problem with this. And the clot retraction can shear and damage the photoreceptors. And the presence of blood basically mechanically separates, and it acts as a barrier actually for the nutrients to go either way, and finally leads to disciform scar. And we have got different grades. The mild with half DD and moderate is up to 2 DD, and more than 2 DD is severe. Especially if it is more than 2 DD, or if it is 2 DD and anterior to equator, we go for surgery. The good visual prognostic indicators include a shorter duration, which is, subretinal hemorrhage, and eyes with good vision. But if it's a relatively larger, more number of days it's staying under the retina and the eyes with the AMD, then the chance of visual recovery is usually bad actually. So we have got a lot of options, right from observation to vitrectomy to the injection of TPA and pneumatic displacement. But we'll be confining ourselves to the submacular surgery. So first option will be, we'll just intravitreal gas alone. If it's a mild or moderate, especially in case of trauma where there is a choroidal rupture, we usually go for SF6 because 14 days is more than sufficient for displacing the blood. But only thing is the patient will have to maintain the face down position, maybe 0.3 to 0.5 will be sufficient. And before injecting, just look for any breaks inferiorly. Any breaks inferiorly, and if you inject gas, there is always a traction on the retina, and the chance of detachment is very high, and you can have vitreous hemorrhage also. And sometimes you can combine that with anti-VEGF agents. This is a case of a choroidal tear, and this patient is quite fortunate actually, because the choroidal tear, it's not passing through the fovea, it's temporal to the fovea, injected with the gas, and this is the final result. The blood is absorbed or displaced laterally and got absorbed. Patient is having good vision, but of course there will be a scotoma, and we have to keep on watching this patient because maybe after 8 months or maybe later on, there is every possibility that this patient can develop SC and VM. And the most interesting part is the surgery for the subretinal heme in this case. This is a case with vitreous hemorrhage with subretinal blood. So what we basically do is you do a nice vitrectomy after clearing the vitreous hemorrhage. It's like artificially creating a giant retinal tear. Cauterize, I usually go for 180 degrees because when you are removing the blood and the membrane, it's quite peaceful. So cauterize 180 degrees in the periphery. And now you have to induce the retinal detachment. It is very easy, like in a silicone oil injector, take the balanced salt solution, mount it on a 44 gauge needle. Don't inject manually, mechanically injecting is fine. So it is like connected to the silicone oil injector. Just keep pressing how you inject the silicone oil and keep the 44 gauge under the retina. Make 4 blebs at least in all 4 quadrants. So you can inject. Only thing is care should be taken not to inject under the RP, but you can realize when it's going under the RP, but it should be under the retina. Neurosensory retina, don't go under the RP. Once the bleb is formed, do a fluid air exchange, and all these blebs will coalesce to form a nice detachment. Okay. So once the detachment is formed, wherever you have done the cautery in the periphery, see to that there is no vitreous posterior to the cauterized area. Any vitreous, if at all present, it should be anterior to the cauterized area. Any vitreous posterior to the cauterized area on the retina will definitely lead to redetachment later on when we do. This surgery can be done bimanually or unimanually. So in this case, you just rotate the flap nasally, and you can see the clotted blood. Because in a clotted blood, TPA will never work actually. Even in chronic clots or chronic blood, TPA never works. So once the clot is removed and the membrane is peeled, then the retina is repositioned with PFCL. So you can find a lot of small clots. Everything is removed. And once it is done, you replace the retina with PFCL and use maybe a Thanos diamond dusted scraper to replace the retina into its position. In case if there is severe damage to the RP, there is always a chance for you to go in for a RP transplant, which can be taken from the temporal retina. Once it is done, replace the retina under the PFCL and treat it like a giant retinal tear. So at least 10 to 12 rows of laser will be required. And 1000 centistroke oil is more than sufficient. So this is the immediate post of the same case, improved to some, I think, 636, not beyond that, and staying stable after. And all these cases where we are operated, I want to mention that they are all single-eyed patients. We don't do this in the, this is another case with, it's not exactly subretinal heme, but there was an organized membrane under the macula with vitreous hemorrhage. So after the vitrectomy is done, you can see there was a membrane. In fact, we have done already the laser also in this case. So now you induce the detachment basically by injecting the balanced salt solution with the silicone oil injector in all 4 quadrants. And once if you do a fluid air exchange again, a nice detachment happens. All the blebs unite to form a nice bleb, and it is comfortable for us to trim the peripheral retina with a cutter. So now the peripheral retina is trimmed. Once it is done, you just fold it, and you can find a nice membrane under the retina. Fortunately in this, the RP was not ripped when we removed it. So the membrane is quite dense. Sometimes it is difficult to remove these membranes with the cutter, so trim it and we'll have to remove it. Same thing, we have trimmed the membrane. You can see that membrane, and this is the post-op OCT and the fundus picture of the patient. And this is the last case. This is again a case of PCV with large subretinal bleed with vitreous hemorrhage. And this surgery was done with ingenuity. So once the vitrectomy is done, same thing. Everything is the same. So sometimes you need to do bimanually also. Here the large clots and the clotted bloods are there, along with some membrane also. Once it is removed, you just keep it over the retina. What happened in this case is the membrane was so dense. We tried trimming it with 20 gauge also. It was not possible. Finally, we extended and removed the rest of the membrane through the sclerotomy wound, and the retina was lasered. And this is the post-op picture of this patient. Unfortunately, this patient, surprisingly, I think this is the best case I can say as far as the vision is concerned, improving to 6/18. And these are some of the cases where we have done. So in case of, in conclusion, in subretinal bleed or submacular bleed, the natural history is very variable as far as the visual outcome, and it depends on what is the etiology and what is the duration also. So in case if it is related to CNV, as in case of a neovascular AMD, usually it carries a very poor prognosis, and especially if it is untreated, usually the patient has got no practically useful vision at all. But very frankly speaking, there is very minimal benefit of submacular surgery as of now, because in most of the trials when they do the submacular surgery, especially for CNVM, the initial vision itself is very poor, so we cannot expect them to give a good vision. But with more and more submacular bleed, I think if you intervene early, I think we can give a better results. And submacular bleed is once, especially in case of PCV, is one such indication where we will be reviving this technique of going in for submacular surgeries. Thank you.
Anish, so the for protocol for positioning after pneumatic, when you are planning for pneumatic displacement, how do you advise the patient to position?
No, but usually they say that rolling and all, but I don't think it is required. If you just push, I mean, put them in the prone position, whatever.
You want them to be 2 weeks position? Like
Yeah, maybe 4 or 5 days is more than sufficient, I think, for the blood to be displaced.
People, I think, advise 1 week.
Yeah, 4 or 5 days is more than sufficient.
Also, the first case which you are showing, you are trying to wash the blood and reposition the retina under air.
Yeah.
Would it be easier to do that under water and PFCL?
No, the thing is actually it was
Subretinal
bleeding
PFCL
too much. So when it was bleeding, even in case of a diabetes also, whenever there is too much of bleed, I usually go in for fluid air exchange, because under the air, the media clears instantaneously, and manipulating under the air is much easier, especially these clots. Once the clots are removed, then we can go in for PFCL, and then we can cauterize. But especially when there is a bleed which is not controllable, the whole globe filled with the red blood, we cannot see anything. In such case, if you go in for a fluid air exchange, it instantaneously clears the media. I think every one of us will be doing that.
Yes.
The third case, like what was the diagnosis? Why was it lasered? PRP, what is the reason for that?
No,
That
actually it was
scar.
in between I was called. It was not actually, the surgery was not done by me. So initially one of our fellow was doing the surgery, then he was doing the laser. So it was, after that he called me that he thought it was just a macular scar, then he called me, then we thought we'll go in for submacular surgery actually.
One last
So
thing, like you watched Gabor doing the macular translocation.
Hmm.
So like, we are
No, the problem with macular translocation is, the problem with the procedure is later on when you are removing the silicone oil, you will have to do the muscle surgery also to bring the, what you call the macula back into the position. So I think we need the cooperation of the squint surgeons. I think.
Apart from that, the ease of surgery and the visual outcomes.
Yeah.
Like in
But I don't think it makes a huge difference actually. So except for one case, none of my cases improved
No,
beyond
not in
660.
this, like macular translocation, I must
No, even in such cases also, I don't think they improve so greatly. Maybe I think we can prospectively see how much of vision improvement is happening in RP transplant under the fovea.
That also has not been very promising. I
Yeah.
feel.
How late have you taken up patients after submacular bleed? Like how early? Early means as early you want to operate, or when do you operate the patient? Optimal time for taking for a surgery like this?
No, like most of you would have seen, all of us would have seen, like in case of PCV, even within 1 week, the blood is, yeah, it is altered actually. So there is no point in waiting. And again, going for submacular surgery depends on the amount of blood inside. We might be doing ultrasound, but exactly when we do the vitrectomy, then we decide whether to go in for the submacular surgery. If it is involving the macula and it is extending up to the or beyond the equator, then we have no other option but to go in for removal of the blood. Otherwise, there is no fixed protocol in the sense in a case filled with vitreous hemorrhage, even though you do the ultrasound, we are not very sure whether we are going to proceed with or not, but we are always prepared for it basically.
Pneumatic subretinal TPA injection and pneumatic displacement, do you do that, or you straight go ahead for
No, we don't. We go in for surgery there.
this surgery only? Okay, thank you. And we now invite Dr. V.R. Saravanan for macular hole surgery in detached retina conditions.
So this is probably part of Abhijit's talk itself, like how to plan ILM peeling in cases where the retina is mobile. So normally when you peel ILM in a routine macular hole case where the retina is attached, so when you peel the ILM, the retina gives you a counter traction. So that it doesn't come along with your forceps. So it gives you a counter traction. Thereby you are able to peel the ILM off the retina. But when you're encountering a person who has got a retinal detachment, then there is no counter traction available because subretinal fluid in the retina is very mobile, and we try to pull the ILM, the retina also gets dragged. One more problem being that when you inject dyes in these eyes, the dye can migrate into the subfoveal space. Then it can lead to either toxicity to the RP and damage to the RP, especially if you're using ICG. And also it can, once the dye goes under the retina, when you peel the ILM, normally you get a white and blue retina where the ILM is peeled and where the ILM is not peeled. You have a high contrast when you use dyes. And when you have dye underneath the retina, then it leads to a loss of contrast also, making you difficult visualizing where it's peeled and where it is not peeled. So we have been using PFCL as Abhijit showed in his last video, that PFCL really helps in these eyes where the retina is mobile. Prior to that, we'll have to address all the other membranes which may lead to subretinal migration of PFCL. So once you have made the retina mobile, you inject PFCL to cover at least from arcade to arcade, and then you inject here the dye, which are either, this is actually one of the older cases where you're injecting trypan blue. You can also use brilliant blue. So whatever you're injecting, you have to reach the level of the retina and the PFCL, because all these dyes float because PFCL is heavier. And if you're injecting these dyes within the PFCL bubble, it is going to float up and not reach the retina. So if you want to prevent damage to the retina, you can also use a soft tip, so that even if you touch the retina accidentally with a hard tip, it doesn't damage the retina. So here there's a hard tip, so you have to be a little bit more careful, steel tip. Soft tips are much more better and much more safer when you're trying to inject very close to the retina. And if you normally 1 or 2 drops is enough, but if you injected more than that, you can sort of remove those so that visualization becomes much more easier. Then once you have done this, then it becomes easy to peel the ILM. So only problem being that normally the ILM doesn't float up because of the PFCL pressure it's applied onto the retina. So picking up edges may be a little bit difficult, but it's a small learning curve which you can learn very easily. So otherwise it's very easy. But some people also prefer to peel without PFCL. Then the direction of peel should be from the disc towards the periphery, so that the disc will offer some amount of counter traction. If you're not used to doing that, then you always use PFCL and then peel according to whichever direction you are comfortable with. So one more case where we are, the previous was a traumatic retinal detachment. This is a routine age-rated patient with a peripheral tear. You can see same technique where the dye is being released. You can see how it's floating up if it is not released at the edge. So you have to go really to the junction of the retina and the PFCL bubble, and then you can really raise the edge with either a pick or a Finney loop or a Thanos, whatever you prefer, and then go ahead with this. So why normally there is some controversy on whether to really peel the ILM in such cases, because already we're dealing with a much more grievous disease. But it helps to improve the visual acuity, final visual outcome once you touch the retina. And then also I think think one of the free papers which are presented in the VRSA by Dr. One of the past presidents, he showed that in eyes where he did not peel the ILM, in a short series of 5 cases, he said that visual acuity was much worse than the control groups. So it makes sense to peel ILM even in eyes with the significant RD when there's a coexistent macular hole. So this is the second thing which you want to discuss, how to remove PFCL, which is an iatrogenic complication where the PFCL is captured under the retina. So first is to prevent, how to prevent subretinal migration of PFCL. One thing is to make sure that you inject PFCL after the retinas. Once you peel the membrane, the retina becomes less stiff and more mobile, so that there's a lesser risk of subretinal migration. And second time when you inject PFCL, either you inject to cover the break totally, so that there is no free space left, or you inject very less so that it is below the level of the break. So when you inject in between, where the PFCL edge is overriding the break, then there's when you move the eyes and the bubble breaks up, then subretinal migration is going to be higher. Also, you can use third indication where it happens is when you remove the instruments and there's a turbulent flow going from the infusion, it breaks the PFCL into multiple small bubbles. To avoid that, you can use valved cannula so that there is no turbulence and the PFCL does not break. So one is to make the retina mobile. Second is to inject either totally below or totally above so that there is no edge of PFCL overriding with the break. And last is to use valved cannulas to prevent turbulence whenever you are exchanging instruments. But in the event it happens, why should it be removed? Because PFCL is toxic to the retina and it is going to cause permanent scotomas if left alone. And the timing should be intervene as early as possible, because beyond 50 days it's going to cause, you cannot say that I'll remove the PFCL along with the oil removal, because beyond 50 days it has been shown to be toxic and has been shown to produce permanent scotomas. Peripheral PFCL producing peripheral scotomas is not a significant thing, but when you have a subfoveal PFCL, it's going to hamper the final visual recovery. So there are two techniques which have been mainly practiced, more popular techniques. One is to induce a sort of localized, as Naresh showed in his previous case, using either a 39 or a 41 gauge needle, inject a small BSS to produce a localized bulle of retinal detachment, and then mobilize the PFCL bubble from the subfoveal space to a peripheral location from which it can be aspirated using your soft tip cannulas. So this way you're not making any injury near the fovea itself, which will be the second technique. So in the event that you're not having access to a 39 or a 41 gauge needle, you can also use the 30 gauge needle, which this technique was taught to me by Dr. Abhijit here. So what we do is this 30 gauge needle, we try to break it from the hub and then insert it into a 24 gauge needle, so that it makes the tip is base is 24 and the tip is 30. So you have to make sure that when you bend, that here there is no, the tip of the 24 gauge needle is made flat, and also this curve is in such a way that the axis near the macula will be parallel to the RP, so that you don't hit the RP and cause a bleed there. So this is an alternate to using the 39 or 40 gauge needle. In case you don't have access, sometimes it happens that you, after go to theatre, you realize that this case in the list and there's no, because on the reusability of the 39 and 40 gauge needle is not that very great, and they tend to get blocked very easily. So here what we are doing is one of our cases where, because it's being a bent contraption, I mean it cannot pass through a cannula. So you have to remove the cannula and then you may have to readjust the bend according to your, once you reach the fovea, you have to make sure that this edge of the needle is parallel to the RP, otherwise you're going to hit the RP and cause a bleed there. So just insert it sub neurosensory just below the retina, and then use either the automatic injector, or the nurse can inject from the syringe, and by drop you can just insert so that you form a localized bulle, and the bulle should just stop at the fovea. So once you try to inject more and more, the fovea will rupture and cause iatrogenic macular hole, because the pressure inside the cavity is very, very high. So once the fovea becomes elevated, just stop there to avoid iatrogenic macular hole formation. And then with the soft tip, 27 gauge is better to minimize the injury at this level. So whichever is available, best 25, if not that 23 also. You can try to stroke the fovea gently and push the bubble from the subfoveal space to the edge of your retinotomy. And then when you aspirate along with the BSS, this PFCL bubble also will come out. So if it's a very small hole and not much of damage is there, you can leave it without lasering also. It doesn't progress to RD. But in case you have injured much, then you can also do a laser to prevent recurrent retinal detachment once the oil is removed. This was immediately the second or third day after the first surgery, so we are trying to remove it immediately to avoid permanent damage to the subfoveal zone. Second technique is that where we make a small rent in the retina at the edge of the PFCL, and then use either a 25 or a 27 gauge cannula to just aspirate it, or sometimes you can use the 40 gauge needle itself, but it's very tedious. We have to be a little bit careful not to engage the retina also. So either one of this can be done. Either the same needle can be used to aspirate, or you can use a soft tip to, because we didn't have that 41 gauge needle at hand. So this is one of our pediatric cases where there was a leftover JRT patient. So just make a small, this is a 27 gauge needle where we are making a small prick with the 27 gauge needle, and then using the 27 gauge soft tip cannula to aspirate the PFCL from the edge of the, it was during the SOR we realized that there was a small PFCL bubble. Because a very small kid, we were not able to identify this in the immediate post-operative period. So both these techniques can be tried in the event that you encounter a post-operative complication of retained subfoveal PFCL. Thank you. So any questions for any of the speakers in this session? We can entertain it right now. Yes, Manisha.
You, sir.
Yeah.
No, first thing is like, in case if you are peeling the ILM, and if the macular hole is not closed in RD.
RD is not attached, or macular hole?
No, RD is attached, the hole is not closed.
Okay.
So, what would be your next option? You want to put the capsule under the silicone oil? Or
whatever is at hand, you can do that.
No. Jokes apart. Jokes apart. In case if you want to deal with that, you will deal with that at the time of silicone oil removal, or at any time earlier?
No. During, if you want to deal with it, better to deal at the removal. As you said, right now, as George rightly pointed out, the first treatment of choice is the free flap. So I also tried hinged flap also. But initially that was before I started using PFCL, because first 2 cases I lost the free flap. Then third case I tried my hinged flap. Then I started using PFCL. It was much more easier now.
Now, how about filling it with retina actually?
Yeah. I have not tried,
but that was used for in literature. This schisis, traumatic macular hole, foveal schisis. They have one surgery failed, and they didn't have the getting another ILM. ILM stain itself, because of the lack of contrast, was first surgery itself they found it difficult and it failed. So then they didn't have anything, no ILM there. Now what to do? They didn't have, left with no options. So what they did is they filled PFCL, cauterized one circular area in the temporal mid-periphery with the forceps under PFCL, just shifted that piece and put it on the macula, and general PFCL, that's what it's taken up. After I showed the picture after 6 months, hole is that in that staphyloma, hole closed, and that retinal tissue is taken up. Vision at from 4/60, it has come to 624. Now, only thing they caution is when picking from there and bringing the same side of the retina. Don't flip the retina, because the RP side should not come on a. So
the opposite part will be seeing better.
So these. So these are all the techniques. So why this capsular technique we used is because initial all described surgical techniques, the technique we showed, PFCL. Under PFCL, it's quite easy. That video which Dr. Sarandan has done, the temporal flap under the PFCL is just shifting. There is no question of losing the flap. Initial techniques, what described, pick it up, no, and not under PFCL. So
the first case was 2 times failure. The posterior capsule was the first case. That was a second time failure, and that's why we do it. Yeah, Manisha.
So maybe, George, what you are suggesting, we may also land up writing our initials on the piece of retina like DSEC people do. Okay, I just wanted to share that, Saravanan, the technique that you've showed for ILM peel under LPFC in a case with RD, another way of going about doing the ILM peel, because sometimes, as you rightly mentioned, under LPFC, it provides a kind of a pressure downwards, and it becomes more difficult to actually lift up the ILM. Another way of doing it, the way I routinely do, is that I do an FGE and flatten the retina. And after that, again, you start the fluid, because the retina is settled, and once you've again restarted the fluid, it's not so much detached.
So much mobile.
And then under fluid, you just go ahead and do like a routine macular surgery, ILM peel.
As I said, that you may also want to direct the direction of peel from the disc towards the periphery, so that.
But after you've done an FG, do your dye injection, flatten the retina, restart the fluid, and do the ILM peel. So there's no need of an LPFC at all.
Thing is, when in a fresh case of RD, the mobility is always an issue. Whether you do this FGE and try to remove most of the subretinal fluid, I still feel once you start pulling, that depends on if it's like chronic RD, where the PVR is slightly and the retina, inherent stiffness of the retina, there you may get.
But if you've done an extensive membrane peeling and if you have flattened the retina very well, and once you've done an adequate.
No, what I'm saying is when the retina is stiff, the movement is less. But in a very fresh case where there is no PVR, there will be some amount of play. That means the loss of counter traction will be there. So in those cases, you try to counter it by using the forces always directed towards the periphery.
Absolutely. That is always much easier to do. Yes.
No, again, the advantage of using PFCL is no need for waiting actually. The staining is instantaneous.
That is true. That instantaneous. Because the dye does not escape anywhere.
Yeah,
it is instantaneous staining.
And just a caution of word for all actually, because we all operate and everybody has their own technique. Actually, they'll say everything is fair and war and love. Actually, we have to include surgery also, because everything is fair in war and love as well as
you have to look at it from the patient's point of view
exactly.
also.
And see, most of these things are all not level 1 evidence, not even level 4. Like this is all level 5 evidence. It's beyond personal, because everybody has got their own technique and no technique is inferior. Whatever is comfortable with each and everyone.
That is true.
You have to follow actually. There is nothing called this is the best or that is the best. So every technique is best provided if you are comfortable and not doing much harm to the patient actually.
So only one question is left to Dr. George, that this free flap technique, what about putting the chandelier and closing the infusion, and then bimanually it is much easier to put the free flap there.
So one of the to prevent loss, some people have tried direct PFCL oil exchange.
In this free flap technique also, retinal free flap technique also, they have done a direct oil PFCL exchange
to prevent migration
of the after when PFCL removal time, because the full thickness retinal flap is just placed on the not tucked in. So they have done a direct oil PFCL exchange.
Thing is, when you start aspirating the fluid, the PFCL, it starts to move around. So some people have tried to use the oil, because oil is the mobility of tissues under the oil is very, very less. So instead of putting air and trying to aspirate, they have tried to inject directly like you do in a GRT patient.
Yes, exactly.
So if there are no more questions.
One more question from me. Actually, I was just looking at those videos, and I wonder if we could place those free flaps under air. Is there any problem?
No, under air it doesn't leave the forceps. It's very sticky. The forceps sometimes doesn't let go of the.
Especially which.
So these are flimsy membranes, and once you hold it, when you leave it there, it will not let go. It will stick on like a Fevicol. No, you try to take it off. Always, if it keeps sticking in your fingers, a bubble gum, something like that. It's not easy to let go of the flap under air. I have tried it, and I feel actually I was not complete. Huh? Yeah. It also rolls up also.
Under BSS you can do it. That I'm telling. So if you have to close the infusion, because that causes the turbulence and you lose the flap. We have done it under BSS and with chandelier with bimanual.
That anterior capsular
flap.
Anterior capsular flap was actually placed under
air. The capsule is a little bit thicker and stiffer, so that is easy. But ILM is very flimsy.
Yeah, capsule you can place with a drop of visco.
I remember in one of the RetNet meetings, Dr. Trehan was showing the free flap, and he had to do it like 5 or 6 times before he got the flap. Every time he peels, it will disappear. Then the 5th time or 6th time, he was successful in not losing the flap. There's a very funny video which he was showing in one of the RetNet meetings. So even Shukla was commenting like, how many times did you peel the ILM?
Okay, I think if any more questions? No. So I think we'll wind up the session. We are right on time, and thank you everybody for coming. Thank you, Dr. Abhijit.